Assalamu alaikum. Now I would like to discuss about the eating disorder most common in young women. In eating disorder, there is anorexia nervosa, bulimia nervosa, pica, and rumination disorder. First of all, jumping into the anorexia or bulimia nervosa, first of all, I would like to discuss about these two things. In anorexia, BMI is less than 18.5, intense fear of weight gain, and distorted views of body weight and shape. Distorted views of body weight and shape. Treatment is CBT, cognitive behavioral therapy, nutritional rehabilitation, and olanzapine. If no response to above, CBT and nutritional rehabilitation does not work, olanzapine can be given. Olanzapine can cause obesity. And in bulimia nervosa, there is binge eating and inappropriate compensatory behavior. Inappropriate, there is recurrent episodes of binge eating and inappropriate compensatory behavior to prevent weight gain, like prolonged cycling or weightlifting or use of purgatives. CBT, nutritional rehabilitation, and SSRI fluoxetine can be used, often in combination with above. And in binge eating, recurrent episodes of binge eating, but no inappropriate compensatory behavior, lack of controlled eating. In here you can give CBT, behavioral weight loss therapy, SSRI, and least uh, dexamphetamine, least dexamphetamine. So in here what happens, BMI is less than 18.5 for adults. There is bradycardia, hypertension, hypothermia. There is bradycardia, hypoten. There is bradycardia, hypertension, hypothyroidism, osteoporosis, lanugo, and amenorrhea. Why amenorrhea? There is low calorie intake, decreased leptin, decreased gonadotropin releasing hormone, decreased LH and FSH, decreased estrogen, and thus causing these amenorrhea. Thus causing this amenorrhea. In binge eating disorder over in here recurrent purging behavior, laxative and diuretic abuse, self-induced vomiting, and binge eating over the last 3 months associated with hypokalemic, binge eating or purging type, restricting type, and refeeding type. In anorexia nervosa, there is binge eating or purging type. In binge eating purging type, they are using laxatives, and restricting type is primary disordered behavior include dieting, fasting, and over exercising, no recurring purging behavior or binge eating over the last 3 months, and refeeding um, often occurs in significantly malnourished patient with increased insulin, decreased phosphate, potassium, and magnesium, and decreased phosphate, potassium, and magnesium, cardiac complication, rhabdomyolysis, seizure, nutritional rehabilitation, psychotherapy, and olanzapine should be used. And bulimia nervosa is a recurring recurrent episodes of binge eating with compensatory purging behavior at least weekly over the last 3 months. BMI often normal and slightly overweight, associated with parotid gland hypertrophy, enamel erosion, Mallory-Weiss syndrome, electrolyte imbalance, metabolic alkalosis, dorsal hand calluses from induced vomiting. There is Russell sign. Treatment is psychotherapy, nutritional rehabilitation, antidepressant, SSRI, and bupropion is contraindicated due to seizure risk. Bupropion is contraindicated due to seizure risk. Bupropion is contraindicated due to seizure risk and binge eating disorder. And in binge eating disorder, recurring episodes of binge eating without purging behavior, recurrent episodes of binge eating without purging behavior, at least weekly, weekly over the last 3 months, increased diabetes risk, at least weekly over the last 3 months, increased diabetes risk, most common eating disorder in adults, most common eating disorder in adults. Treatment is psychotherapy, first line SSRI and lisdexamfetamine. And pica is recurring episodes of eating of non-food substance like ice, dirt, hair, paint chips over more than 1 month, over more than 1 month. In pica, recurrent episodes of eating of non-food substances like ice, dirt, hair, paint chips over 1 month. But in bulimias and in anorexias, um, this is last 3 months. But in here, pica is more than 1 month. Common in children or during pregnancy, associated with malnutrition, IDA, developmental disabilities, and emotional traumas. Develop- Emotional traumas. Psychotherapy and nutritional rehabilitation. First line SSRI is the second line. Psychotherapy and nutritional rehabilitation is the first line, and SSRI is the second line. Gender dysphoria. Lots of patient is found nowadays about gender dysphoria, significant incongruence between one's own gender identity and one's gender assigned at birth, lasting more than 6 months, leading to persistent distress. Individual experience marked discomfort with their assigned gender, which interferes with social, academic, and other areas of function. Individuals may pursue multiple domains of gender affirmation, including social, legal, and medical. Transgender is any individual who transiently or persistently experience incongruence between their gender identity and their gender assigned at birth. Some individuals who are transgender will experience gender dysphoria. Non-conformity to one's assigned gender itself is not a mental disorder. Sexual dysfunction, a differential diagnosis is penis. That means it is psychological. Sexual dysfunction include sexual desire disorder, hypoactive sexual disorder, or sexual aversion, sexual arousal disorder, erectile dysfunction, orgasmic disorder, anosmia, premature ejaculation, sexual pain disorder, genitopelvic pain, or penetration disorder. These should be included in sexual dysfunction. Sexual disorder like hyperactive sexual disorder or sexual aversion, sexual arousal disorder, rectal dysfunction, orgasmic disorder like anorgasmia and premature ejaculation, and sexual pain disorder, genitopelvic pain or penetration disorders. Differential diagnosis includes penis, psychological, endocrine, diabetes, and low testosterone. Neurogenic in post-operative spinal cord injury, insufficient blood flow like atherosclerosis, substance like antihypertensive, um, antidepressant, and ethanol. These are the drugs can cause sexual dysfunction. In sleep terror, in sleep terror disorder, periods of inconsolable terror with screaming in the middle of the night, most common in children, occurs in slow wave N3 phase, non-REM sleep with no sleep terrified, terrified, non-REM sleep with no memory of the arousal, opposite nightmare. Remember, right? Nightmare is remember that occurs during REM sleep and remembering a scary dream. Triggers include emotional stress, fever, lack of sleep, usually self-limited. So sleep terror and sleep night terror and nightmare is different. In night terror, patient gets terrified, no memory, non-REM, and a nightmare is memory, remember, REM. This is sleep terror. Terrifies, abrupt arousal from sleep, panic, scream, terror,
I
autonomic.
can't reach the internet right now. Check your modem or router connection and try again.
In sleep terror, there is little or no dream recall. Terrified, no dream recall, amnesia for episodes. Reassurance, administer low dose benzodiazepine at bedtime if episodes are frequent, persistent. So, sleep terror, type of parasomnia that occurs during non-rapid eye movement sleep, characterized by episodes of screaming, crying, during which the child is inconsolable and cannot be fully awake. Flushed face, sweating, tachycardia is common. No memory. Most commonly seen in child 2 to 12. Peak incidence is 5 to 7. Sleep terror. Slow. So sleep terror is the most commonly seen in children age 2 to 12 with peak incidence at age 5 to 7 in healthy children with a classic presentation. The diagnosis is clinical with no further workup is required. Patients parents should be reassured that sleep terrors are not dangerous and usually resolve spontaneously within 1 to 2 years. That's all about sleep terror. Then aneurysm. Aneurysm is a nighttime urinary incontinence, 2 or more than 2 times per week for 3 months in a person more than 5 years old. 2, 3, 5. Two aneurysm is 2, 3, 5. First line is behavioral modification, schedule void, nightmare, nighttime fluid resuscitation, and positive reinforcement. For refractory cases, bedwetting, alarm, oral desmopressin, over oral dosage preferred over imipromine due to fever side effect anabiosis. Nighttime urinary incontinence, two or more than two times per week for more than 3 months in a person more than 5 years old. First line treatment behavioral modification for refractory bedwetting alarm oral desmopressin preferred over imipramine due to fever adverse effect narcolepsy. Recurrent lapses into sleep or naps, three or more than three times per week for more than 3 months. In DSM-5 criteria, recurrent lapses into sleep or naps three or more than three times for 3 months with one of the following: cataplexy, brief loss of muscle tone precipitated by strong emotional laughter or excitement, low CSF fluid hypocretin, shortened RAM sleep latency, shortened RAM sleep latency associated with hypnagogic and hypnagogic hallucination, and there is sleep paralysis. Treatment is good sleep hygiene, scheduled nap, regular sleep schedule, daytime stimulant, amphetamine and modafinil, and nighttime sodium oxybate. In here, in narcolepsy, there is decreased hypocretin production in the lateral hypothalamus, uh, and dysregulated sleep cycle. Hypnagogic or hypnagogic hallucination, nocturnal and narcotic sleep episode that with REM sleep, sleep paralysis, and cataplexy. Substance use disorder, a maladaptive pattern of substance use involving two or more than two of the following: tolerance, withdrawal, intense distracting cravings, using more or longer than the intended, persistent desire but inability to cut down, time consuming substance accusing, impaired functioning at work, school, home, social or interpersonal conflict, reduced recreational activities, one or more than one episode involving danger, unsafe sex, driving while impaired, continued use despite awareness of harm. Now, gambling disorder. This is the last topic. Gambling disorder. Treatment is psychotherapy. Persistent, recurrent, problematic gambling that cannot be better explained as a manic episode. Diagnosis may if patient meets four of the following criteria: is preoccupied with gambling, requires more gambling to reach the desired level of excitement, has failed efforts to limit or cut back or stop gambling, gambles to escape or relieve feelings, helplessness, guilt, anxiety, depression after losing money, gambling, continuous gambling in an attempt to recover losses, lies, inconceal the extent of gambling, put at risk and has lost significant relationship, careers, or academic pursuit because of gambling, relies on money from others to fix financial collapse due to gambling. Treatment is psychotherapy. That's all about psychiatry. Hope you enjoy.